Andreen van Schaik. I'm the Vice Chair for Education. Recording is in progress. I'm the Vice Chair for Education in the Department of Pediatrics, and Dr. Hirsch regrets that he's not able to be here today and has asked me to welcome everybody. It's nice to see so many people here. You're a week too early, so you have to come back because next week we will have lunch again. Finally, yes, sorry. Liz has asked me to not do formal introductions, but I don't actually listen to Liz. So I just want to briefly say that you'll probably all know Liz Rogers. She is a professor of pediatrics with a clinical appointment in the Division of Neonatology here at UCSF. And she carries more official roles now than I can possibly memorize, so I didn't. So it will not be a very formal introduction from that perspective, but she's really just such a great positive force in our department to make all kinds of things happen around physician experience, around the neonatology experience, clinical research, and then all of this, getting all of you or this big group of people here that are involved with the projects around Kangaroo care. So Liz, with this informal, not so formal introduction, I hand it over to you.
I know. Thank you. Well, Sandrine, don't introduce me, but thank you so much. I'm thrilled that people are here and continue to come in. We also, last I checked, had over 50 people joining us on Zoom. So thank you from wherever you're joining us from. So I'm going to take very little time because we have many people to hear many important things from. So I'm just going to get us going, but I'm really grateful to have you here. Many of you know that our intensive care nursery and our pediatrics department generally is really on a journey towards centering our patient and their family in our care. And this is a critical time right at birth that we have an opportunity to do that and to really set the stage for families as partners throughout their time in pediatrics and then obviously well beyond. So leading us off and moderating our panel of true international experts who we're so honored to welcome today is Dr. Jana Patterson. She's the Senior Vice President of Global Child Health and Life Support for the American Academy of Pediatrics, where she leads the global training and implementation programs. But prior to the AAP, she was a Senior Program Director for the Bill and Melinda Gates Foundation, where she managed a large portfolio of grants on maternal and newborn health. Prior to that, she was a neonatologist and still is, but she practiced neonatology at the University of Washington, Seattle Children's Hospital. She is a great friend to all in global newborn and child health and to all of us in neonatology. And we're thrilled that she is leading this effort of immediate kangaroo mother care. So thanks so much for coming and bringing all of your friends to join us, Jana.
So much, Liz. It's really exciting to be here today in person. San Francisco is one of my favorite cities in the world, so it's fun to be back here. Before I introduce our panelists, I wanted to just tell you a little story. It's a bit of an origin story of this study, and many of you perhaps didn't get a chance to hear some of the study results in the video we were streaming before, but I encourage you to go find the study and read it if you haven't. So when I came to the Gates Foundation in 2014, everybody was talking about the low uptake of kangaroo mother care, which of course had been implemented in Colombia and other areas around the world for decades, but really wasn't getting that good uptake. So I started talking to pediatric healthcare workers, including neonatologists and pediatricians around the world. And of course, there were many reasons why there wasn't great uptake, but there was one conversation with a very prominent Indian neonatologist that stuck in my mind. And he said, Jana, by the time babies are eligible for KMC, the most fragile babies have already died. And we know that almost half of under 5 deaths around the world occur in the neonatal period, and about a third of those deaths are in the first 24 hours. And about that same time, an innovative doctor named Niels Bergman wrote to me and insisted on meeting me to talk about KMC. So I told him I had about 30 minutes before my flight on a Sunday morning at the Durban airport. And I thought that might deter him, but no. Niels is a very persistent man, as many of you may know. And he showed up to meet me at the Durban airport with a PowerPoint deck of close to 100 slides. Yes, really. Teaching me about the neurobiology of KMC and linking it to his PhD research on spider bites. At the time, I thought, this man is either a creative scientific genius or But I listened and I thought about what he said, and I talked to others and realized that he had something very meaningful in those neurobiology slides. So this began the journey of a planning grant that was led by Bjorn Westrup, who you'll hear from in a little bit, to determine how we could work with WHO to test this idea that kangaroo care can actually promote stabilization of babies and save many more lives in the first 24 hours, as opposed to an intervention that has to wait until a baby is stable. So as you heard from Dr. Rao in the video, the results of this study were published in the New England Journal of Medicine last year, 2021, and showed a significant reduction in newborn mortality. Publishing a randomized trial is, of course, an important step in changing practice, but we know it's really only a tiny, small first step. The results need to be discussed, shared, and demonstrated. And so we continue this journey today here with you. We are bringing the sharing, discussion, and demonstration to you after starting in Nigeria and then Brazil. I bring a bit of that journey today on my person with a beautiful coat gifted to me from Professor Abun when we were in Nigeria, and a little bit of Brazil on my arms. So it is with great pleasure that I introduce you to our panel of experts, each of whom played a seminal role in the original trial. So first, I will introduce Professor Harish Chelani, who is joining us from Delhi by Zoom. He is, as I said, a professor. He's in charge of the newborn unit at Safdarjung Hospital in New Delhi in India. He's been involved in many randomized controlled trials over the years with WHO, the Department of Biotechnology, and the Indian Council of Medical Research. Next, I would like to invite Professor Ebun to the stage. Professor Ebun Adejuyibe is a professor of pediatrics and child health at the Obafemi Awolowo University in Ile-Ife, Nigeria. And she's a consultant neonatologist at the Obafemi Awolowo University Teaching Hospital Complex, and has previously been Dean of the Medical School at OAU. And she's been a part of many studies led by WHO as a principal investigator in neonatal emollient studies, the AFRINEST trial, ACTION trial, and of course, this iKMC trial we're talking about today. Welcome, Professor Ebun. And Dr. Bjorn Westrup from Karolinska Institute in Stockholm. He's a senior consultant in neonatology, and in 1999 was the founder and director of the Karolinska NIDCAP Training and Research Center. He's also been one of the pioneers in scientific evaluation and dissemination of infant and family-centered developmental care. Dr. Westrup has a long and close collaboration with parent organizations and serves on the scientific advisory board of European Foundation for Care of Newborn Infants. Welcome, Dr. Westrup. So first, I would like to invite Dr. Chelani to share a bit of his experience with the iKMC trial in Delhi. And he's going to do that via recorded presentation.
Good morning. At the onset, I am thankful to American Academy of Pediatrics, especially Dr. Jenna Peterson and her team for the opportunity to present before you about the immediate kangaroo mother care implementation at Safdarjung Hospital, New Delhi, India. I will discuss what are the opportunities and challenges involved in caring mother-baby diet together in NICU. Immediate KMC study led to the concept of mother newborn care unit, where mother baby diet stay together from birth till discharge, which has resulted in improvement in survival and quality of care of small and sick newborns. The iKMC intervention required continuous skin-to-skin contact with mother or surrogate starting within 2 hours of birth, aiming more than 20 hours per day, support for exclusive breast milk feeding, and provision of medical care to both baby and mother in skin-to-skin contact as far as possible. Implementation of this intervention required initiation of KMC in delivery area, transportation in KMC position, and creating mother newborn care unit for small and sick babies to ensure zero separation. Mother newborn care unit is a facility where small and sick newborns are cared with their mothers 24/7 with all facilities of level 2 newborn care and provision for postnatal care to mothers. Setting up such a unit required infrastructure for care of mothers, including a washroom, bathing area, pantry, and a clinical examination cubicle for mothers, as these mothers stay in MNCU 24/7 for several days. Like conventional NICU, all equipment for level 2 intensive care, including radiant warmer, continuous positive airway pressure machine, oxygen, suction facilities, vital monitors, phototherapy units, etc. are available in MNCU. Caring small sick newborns in MNCU led to number of gains and successes. In conventional NICUs, mothers visit NICU intermittently for providing KMC and breast milk feeding. As a result, median hours of KMC per day in NICU is only 1.5 hours, while mothers being with their babies 24/7 in mother newborn care unit result in prolonged and effective KMC. In MNCU, babies receive median duration of KMC of over 17 hours, including for the babies on respiratory support. Since mother is with her baby in MNCU, express breast milk is readily available as first feed for initiation soon after birth. Kangaroo mother care results in better lactation, and it is easier to maintain babies on exclusive breast milk feeding by day 7 or before discharge. Mothers in MNCU substantially contribute to care of babies, including feeding, changing diapers, and monitoring babies for danger signs. MNCU provides opportunity for mothers to be primary caregiver, thus providing family-centered, developmentally supportive care to newborns. Presence of mother in MNCU gives ample opportunity to healthcare personnel to discuss with the mothers healthy practices of neonatal care, thus preparing them for taking care of neonates after discharge. However, there were several challenges were faced and we overcame them in providing care in mother newborn care unit. iKMC stand for immediate and continuous KMC after birth. Mother need to be observed for about 2 hours after vaginal delivery and 6 hours after cesarean section, while sick small newborn need early transfer to NICU for monitoring and management. This challenge was overcome by having a surrogate in the delivery area for transporting baby to mother newborn care unit in KMC position. Experience of transporting small and sick newborns in KMC position showed that KMC transport is feasible, although most KMC transports were done with surrogates. 98.2% babies received in MNCU were euthermic following KMC transport. Also, respiratory distress stabilized better in significant number of babies during KMC transport. Babies requiring respiratory support were transported in KMC position with CPAP also. Once babies reached MNCU, CPAP was continued in KMC position itself. Learning to provide CPAP in KMC position was an important challenge. Nasal interface for CPAP is optimized and standard operating procedures for fixing it appropriately have been developed and implemented. A pulse oximeter is constantly used to monitor heart rate and oxygen saturation from birthing place during transport and in MNCO. A binder is used to maintain the baby's neck in slightly extended position. When iKMC study was implemented, healthcare providers and administrators were concerned of potential increase in infection by presence of mother or surrogate in MNCO. However, results of iKMC study show that suspected neonatal sepsis was 18% lower in MNCU as compared to conventional NICU, and sepsis-related mortality was 36% less in MNCU, and both were statistically significant. Even gram-negative infection rates were less among babies staying with mother 24/7. Providing care to mothers from a few hours after birth was an important challenge in MNCU. An essential maternal postnatal care package was developed, and neonatal nurses were trained in implementing this package. Obstetricians take daily clinical rounds for mothers and attend immediately to their urgent needs. New evidence suggests we must establish practice of zero separation of mothers and newborns. The main issue in most of the hospitals is non-availability of adequate space in existing NICUs. In planning new mother-baby care units, mother's bed, which is presently in the postnatal wards, needs to be placed inside NICU, which require reorganization of the infrastructure. This will also need policy change, that is, allowing mothers and surrogates to stay in MNCU 24/7. After completion of the study in January 2020, MNCU facility has been continuing at Safdarjung Hospital, New Delhi, in spite of COVID pandemic going on. With all COVID appropriate behavior, we have been running this facility successfully throughout the ongoing pandemic with 100% occupancy of 12 mothers with 12 or 18 babies, as many of these have twin babies. So, to make zero separation a reality, we need changes in policy, infrastructure, processes, and most importantly, the mindset of the healthcare professionals. In spite of all challenges involved, the gains and opportunities provided by mother newborn care unit makes it key to the survival and also quality care for these small and sick newborns. Thank you.
Thank you so much, Dr. Chelani. I know you're also available on Zoom, and we'll come to you with questions after the other two presenters have finished. So next, I'd like to welcome Professor Ebun to tell us a bit about the Nigeria experience.
Good afternoon. Yeah, so I want to thank the American Academy of Pediatrics for bringing me here. And I also want to thank the University of California for this opportunity to also share our experiences. So I work in the Obafemi Awolowo University in Nigeria, and I'm sure we all know where Nigeria is. That's the pink colored area, in Africa. And I work in the university that is called Obafemi Awolowo University. Happens to be acclaimed finest or most beautiful campus in West Africa. I wouldn't say in Africa, but in West Africa. And Ile-Ife is somewhere in the southwest of Nigeria. For those who are familiar with Nigeria, it's about 250 kilometers to our commercial capital, Lagos. And so we had this study done in Ile-Ife. Nigeria is the most populous African country with about 200 million, still counting. And we have a high fertility rate of about 5.6. And so we have a lot of newborn, and we're still having a lot of them. And because of so many factors, including the ability for in vitro fertilization, we are even having more babies and more preterms. And preterm is about 15% of our births in Nigeria. And unfortunately, it also happens to be one of the reasons why we have the second highest neonatal mortality in the world. We are next to India. And the rate of neonatal mortality over the years, for over 15 years, has not decreased significantly. Okay, at one time was about 40 in 1990. Presently is about 39 per 1,000 live births. I'm sure you're not familiar with that. And okay, so this is just to show that we contribute 8% of neonatal deaths globally. And I said it's still rising. So the kangaroo mother care in Nigeria, there were, I think, 1 or 2 studies about of 15 children some time ago. Then after then, we had this NGO, international NGO, coming in 2008 and introduced kangaroo mother care to some facilities. Unfortunately, there were so many cultural and social things that did not make it thrive. However, later the Federal Ministry of Health decided to take it up, and we have a document on kangaroo mother care. And also, we hope that the Nigerian Every Newborn Action Plan, which was initially launched in 2016, is also being revised. And we hope that at the Prematurity Day on November 17, the second edition will also be launched again. And my center, which is the affiliated hospital to the Obafemi Awolowo University, it's a recognized center for kangaroo mother care. Not too long ago, I think 2015, I and the chief nurse in my ward went to Malawi to understudy what they actually do so we could do it well. Malawi happens to have had kangaroo mother care for over 18 years. So they have a well-established kangaroo mother care program in the country. And so we learned to do that. And so my hospital had, before the iKMC, the immediate kangaroo mother care study, we had a high mortality with very low birth weight babies. Particularly though it was a tertiary hospital, it's still a tertiary hospital. We didn't even have the equipment to make us level 2. I mean, we didn't have respiratory supports. We didn't have the monitoring gadgets. We didn't have the CPAP to support babies. So we had a high mortality. And the year before the study, that's the year 2016, this is our figure that I just showed. We had about 21 babies who are less than 1 kg, and only 5 of them survived. We had a mortality of 76%. And those who were between 1 and 1.49, we had about mortality of 35%. And then those who were greater than 1.5, about 13%. I would like to say that most deliveries in my country do not occur in the formal sectors. They occur outside the formal sector, even though our antenatal care uptake is a little bit higher than you would expect. But the out-of-pocket payment doesn't allow patients or mothers to come to access care in the hospitals. And also insurance is not available to many people. There is mainly to about 1%, the working class. We are trying to popularize community health insurance, but it's still yet to take root. in my country. And so I'm supposed to talk about my experience in the hospital in where I work on iKMC. Dr. Shilani has just explained the results we got, okay, across the 5 countries where the study took place. And so one of the things we had was monitoring. Like I said earlier on, we didn't have monitoring equipment, but through the study, we were able to get the pulse oximeters. So we had 2 types, the handheld, which you can see on the screen, and also the continuous monitor. And so the handheld monitor was particularly used to transfer mothers or surrogates with the babies from the operating theater or from the labor ward to the NICU. And luckily, our hospital had just been built. At the time we were about to start the iKMC, I mean, the unit had just been built. So we were able to modify the unit. I will go into that. I don't know how this came up, okay? We're able to modify the NICU, okay, to bring in the mother and child. So this is what you can see. You can see the arrangement. So this is within the NICU. And if you look at my left side, you will see some resuscitator and incubators. And then you can see some rooms where we labeled KMC1, KMC2. Okay, so the KMC1, KMC2 were the ones we use for the MNICU. Okay, and you can see that the adult beds were brought into the newborn units, and the respiratory support for baby in the KMC position. You can see the woman on my right. Before this, it's like every other hospital, the newborns were managed by the nurses in the NICU, whereas the mothers were managed by the nurses in the obstetrics end. And so to start this study was a very difficult thing because everybody felt, particularly because we are short of nurses, I can say that we have about 4 nurses in morning duty to attend to about 30 patients, okay, 30 newborn. And then we have about 2 nurses in the afternoon and night duties to attend to the same number of patients. So it isn't easy. Then to bring in additional work by asking the mothers to come into the NICU was not acceptable, particularly because we also had this belief that having mothers in the NICU would increase the rate of infections and also the care of the babies would be suboptimal. So we had to actually do a lot of sensitization program. And in this, we were able to, this is the stakeholders meeting where the whole hospital, particularly those who were in the maternity sections, we had a meeting, to disseminate, okay, the information we had to explain the reasons why iKMC may be beneficial, because then we didn't know the results, but from the little evidence that was available, we knew that this could be the thing we need, the bullet, the magic bullet to reduce neonatal mortality. Okay, and having demonstrated that using videos and all the support that was going to be available, the fact that they were going to have continuous monitoring, that the nurses don't have to go and be monitored to monitor the patients, every minute themselves. They just needed to look at the monitor and know what is happening. So I think that's everybody was willing to try, and so we went about doing this. And initially the study actually employed trained nurses for just to watch over these babies. Okay, and at the end we had to transfer the skill to the regular nurses who work in the neonatal ward. So we converted this to a MNICU. This was already pre-built, unlike the India one you just saw now. That was built because of the study. Okay, and so that was purpose built. We had to convert what we had to do, what we had available to form this. And so we had 4 rooms that were made for MNICU. And once the baby were stable, they were moved into the stable KMC ward, okay, along with the patients who were in the control group. What were our challenges? We had a problem with enrollment. I said earlier on that the delivery rates in the hospitals were small. Okay, so many patients were delivering outside the hospitals, and we needed them to come into our hospital to deliver so we can monitor them and give them the intervention from the beginning. Unfortunately, they rather go to the formal or informal sectors or private hospitals, and they were not willing to transfer the babies in utero because they would lose money. So we had a lot of problems. We had to do a lot of mobilization. We had to go to the radio. We had to convince our colleagues to send down the patients. And then, of course, instability of trained staff, particularly now, it's been even worse. We have a lot of brain drain. Many people moving from our country to developed countries, including the United States, for obvious reasons. Okay, and then, of course, maintaining standard of care. From the beginning of the study, WHO provided all that we needed, okay, to raise every center that was involved in the study to a level 2 NICU. And the other thing was now to train people to maintain that standard of care. Washing of hands, it looks so simple, but it can be very difficult in between patients particularly. So that was an area that we had to train and retrain and retrain. And then workers' strike, which comes up quite often. Suddenly in the hospital, the nurses or the doctors are going on strike. And when they do, you have to look for a way of maintaining services, particularly cleanliness of the ward. Nursing care for mothers in the NICU. Like I said earlier on, nurses were not willing to do this because it was going to give them extra work. So we had to explain what to do, the monitoring, how many times, and the obstetricians having to even come from their own ward to come and see patients in the NICU wasn't a routine thing. And Shilani said something about changing policy so that obstetricians can come and do a round in the NICU. That took some time, but with time, it became a norm. And even now, we still do it because there are not too many women who are involved in this at a particular time. So the obstetricians are willing to come, and then it doesn't add to their work. And of course, their beds are also available since we have moved the mothers into the NICU. Then, of course, hypothermia was a problem initially because in the labor ward, the obstetricians want the air conditioner to be on while they are operating, or else they'll be sweating, and we want the air conditioner off. So that was a lot of problems, and the resuscitation station was actually just next to the labor ward theater. And of course, most of the time the door is open and the air, escaped there. And so that was a big problem we had to do. So we had to put a thermometer there and then put somebody at the door whenever the child was going to be delivered to lock the door immediately, change the way the door closes so that it closes automatically on its own. And also to, sometimes we had to use hot water bottles. We know it could cause burns, but we had to use that. And then we pre-warmed all the things we are going to use, including the carrier. I'm going to show you some carriers that Harish has shown already. And then we have a high incidence of neonatal jaundice in my country. About 40% of the male children in Nigeria are GCPD deficient. So that's, I know that with the preterm load again, that is even higher. So because of that, we had a lot of babies who had neonatal jaundice. But because we are using LED phototherapies, and also because we are also doing intermittent phototherapy, we didn't have any patient that needed exchange blood transfusion. And they could also be exposed, they could have enough time on KMC and at the same time be treated for jaundice. We also know that some people use Billy blankets. Some people use Billy blankets. We didn't have Billy blankets to use. I know they use that a lot in Colombia. So this is just to show you pictures of mothers who applied who use the binders. That's a nurse trying to teach her how to use the binder. Then I'll just say that mothers and healthcare workers had good things to say about it. They said the mothers said they spent fewer days in the hospital as the weight gain was faster. Because when you weigh the baby every day, the mothers, I don't know what they do here, but everybody gathered together and they want to know, and they are all happy, and they had to go home faster. In fact, those who were in the control group were actually asking that they wanted to be in the intervention room, okay? And then some mothers also felt that because they were together with their babies, they didn't have anxiety. They didn't have to be imagining what wasn't happening, like most mothers do when they are separated. And then the cost was less. They had one bed instead of two beds, and they paid for just one bed. So that was saving a lot. And also some mothers felt as if the baby was still in their womb because they could feel the heartbeats of the baby, like as if the baby was still undelivered. And then, of course, they got to know the cues from the babies, when the baby wants to eat, when the baby wants to, wee or something. So they got to used to this. And of course, the health worker said at the end of the day that they preferred it because the mothers were also monitors themselves. They could look at the monitor and say, this baby, the heart rate is going down or the alarm is ringing, and so that was very helpful. And lastly, I think the dose separation policy is made possible by iKMC because for the baby to be with the mother, okay, there's no way you can separate them. And then we need greater training and awareness, okay, so that people can understand what it is and how to do it. And then the impact of iKMC, of immediate kangaroo mother care on the neurodevelopment of the babies are still being awaited. There's a study already done on those babies that we use for the main study. We have followed them up for 2 years, and the results should be out soon. And I would like to say that this is the study team. So we had trained nurses, and you can see Dr. Nils Bergman. He's the one sitting down on the floor. And okay, so these are the nurses and the doctors who were involved in the study. So thank you very much.
So wonderful to see how iKMC looks different in different places. So finally, Professor Westrup, let's see about Sweden.
And you saw Neil's nice outfit, Nigerian outfit, when he was sitting in front of the group. And that was a gift from Evan. Evan was also giving you this. She's a wonderful colleague. I also got those. Okay, my name is Björn Westrup, and I'm very grateful to be invited here. See if I have to, and I have no disclosures to disclose. So I'm very happy that Professor Harish mentioned family-centered developmental supportive care, because I'd like to give you some background on how we reached to this iKMC trial to complement what Jana talked about. Because unfortunately and very tragically, Professor Heidi Lizals passed away this summer, and we'd like to acknowledge the importance of her work, because she helped us to see the newborn infant's strengths and sensitivities. And that's extremely important when you do KMC on these infants. And she also helped us casting light on the importance of involving families from the very start in the infant's care, and also guiding us in the systems changes necessary. So that's extremely important. And she talked about this in the 80s. And I'd like to also say something about what the new generic term that has been developed during the last 5-6 years in Europe and also now in the US. And that is the Infant and Family Centered Developmental Care, IFCDC. And it's a more comprehensive terminology that also not only includes NIDCAP, but other programs. Of course, it's based very much on the leading edge work of Heidi Lizals in Boston, and also on the Declaration of Infants' Rights. So that's important to remember. IFCDC has 3 core principles. First, sensitive care based on the behavioral communication of the infant is an essential foundation for child development, early and later, of course. And individualized care gives the baby a voice of its own. And that's also extremely important. And parent engagement is essential for parents' well-being, of course, and parents-infants relationships, and then consequently, of course, for the development of the child. I will not have time to focus on the first object. I will concentrate on the latter objects, because this is also a diagram that Heidi Lizals produced 30 years ago about how we should look at system change. And I think it's very helpful still. I use it a lot. Sorry. And you have the infant in the center, and then, of course, the other systems, parents and family systems, and the NICU system, and the hospital systems, as we have heard about, that need to be changed, and the community system. And I saw that you need to go to vote in the next 2 weeks, don't you? Because you need to vote on the right party in order to secure the. Anyway, so this started in Sweden very long time ago, and it was actually Professor Lagercrantz, who is a professor in pediatrics and neonatology at the Karolinska, that invited Heidi Lizals to present at a meeting, a national meeting in Sweden in 1989. Can you imagine? And I was happy to be there just by chance with a nurse. And we were very intrigued by the work of Heidi-Lise Als and Deborah Buehler, who at that point of time, she was a PhD student and also co-trainer. And we, with your help and Heidi's help, we trained in NIDCAP in this hospital in the forest area of Sweden. And we did an observational prospective phase-lag design trial, which actually is resembled a little bit of your FICAI trial here with this phase-lag design and washout period between the intervention. And that was a NIDCAP trial. Hugo Lagercrantz wanted us to come down to Stockholm and to do a randomized control trial. And that was very challenging to do that, of course, in these acute circumstances. But we did that and we got it published in the Pediatrics year 2000. But also, I'd like to take the opportunity to mention the help that the Bay Area has been involved in this. And because of the West Coast NIDCAP Training Center, founded by Kathy Vandenberg, I don't know which year, in Oakland. Could you help us with that, Debbie? Someone else maybe? In the beginning of the 90s, I would guess. And then it moved over to Stanford, and that's what's the same period when we did the randomized control trial at Karolinska. They did a study at Stanford as well. And we collaborated with Vera Fleischer. He was an neonatologist by then, and also, of course, Catherine Vandenberg, she was the founder of the West Coast Center, and of course, a pioneer in developmental supportive care in the US and the world, in parallel to Heidi-Lise Als, of course. And Deborah Buehler, you were happy because Deborah got married to a guy from San Francisco, so she moved from Boston over here, and then you have a very good resource at the UCSF because you got the center as well. And she's also president of the NIDCAP Federation International, and we're very, very happy that you're here today. And we also decided to go on to open a center in Sweden, and that was actually the first NIDCAP training center outside the US, and supported again by Professor Lagercrantz and also Professor Svenningsson at the Lund University. So the Lund University and Stockholm University at Karolinska have been involved here. But we also understood, as we got this knowledge and we done this trials, that we actually should continue with the systems change. And that's when this concept of mother-newborn couplet care came into the picture. And when I was preparing this, the couplet care means that you couple the care of the baby with the care of the mother, and continuing with that in the NICU, in the same ward. So that's what we call mother-newborn couplet care. But when I was preparing this, I was thinking, but really, the the Bay Area has been very important in this as well. And I don't really think that Kathy understood this. I never talked with her about it. Now she's unfortunately in Oregon, so she couldn't be here. But in the 90s, she was training nurses at Karolinska Dandridge site. And she trained 4 nurses, and they were very happy about that. And as the obstetricians, we had a fantastic drastic increase in deliveries at the Dandridge site, from 5,000 to 11,000 deliveries per year. Then, of course, we needed to open new floor in the NICU. And then it was these NIDCAP trained nurses that went up to the nurse managers and said, we need to do it differently because we need to couple the care with the mother, and that will be much more effective because we know that we have the knowledge. So and Hugo Lagercrantz was the head of the whole program, and the nurse managers accepted this and supported this, and it was fantastic. So actually, Kathy Vandenberg played a very essential role in the concept of mother-newborn couplet care. So we opened this unit in 2003. That's about 20 years ago, isn't it? And we have published a paper on that. You can talk about that. And then also it gave us an opportunity to do more research. We did a randomized controlled trial on neonatal family-centered care because we had 1 floor with single room and 24/7 presence. And we have the other old floor that was fairly good, actually. in the we had free visiting hours and also it's family rooms. So in order, I don't have time to go through the research, but to summarize, what we have shown or we have reported in these trials is that we had reduced incidence of lung morbidity, reduced total length of stay, especially during the intensive care period, and also especially for the smallest ones, the ones with below 30 weeks, they had a reduction of 10 days, and the whole group of below 37 weeks had 5 days reduction length of stay. That's very important for the hospital administrators. And also we could see improved and attuned mother-infant stress regulation and reduced mother's anxiety and boosted feelings of competence, enhanced breastfeeding at 3 months post-discharge, improved mother health interaction, and child behavioral impairments at toddler's age. And then we have, of course, this global picture. We had to go leaving the high resource setting and do more. And that's how I came into contact with Nils Bergman, who is also a Swedish citizen, worked in Africa, raised in Africa. And I came with a high resource setting and the development of care program, so we could do safe skin to skin. And he had the experience of Africa. So we decided to join, and we asked for funding. And after several years, you responded. And I cannot exaggerate enough your importance in this, Jana. Thank you very much that you listened to Nils. And you actually got this program, the planning grant. But also, you guided us during the planning grant. And you saw that we actually engaged WHO experts, Rajiv Bal. And you remember at the bar in Saigon, Ho Chi Minh City, we came to the conclusion that this trial was growing too much for me as a neonatologist. And we asked and convinced Rajiv to take over the final grant. And he did it so fantastic successfully, as you just heard. And here you can see, this is Professor Chelani who just spoke, and this is Rajiv Bal in the simulation session. So they should have been here, could have been here this afternoon. And Jana, thanks again. But you were brave enough to listen to us, and you were wise enough to guide us. Thank you. And now it's time for Stina's video. She has made this before, and maybe I could need some help to start it.
We're gonna take a pause there for a moment, Bjorn, because we only have 10 minutes left, and I want to make sure that people have the chance to ask some questions, and then we'll play the video at the end. Okay?
Yes.
Okay. So yeah, why don't you come on over this way with your chairs? So I'd love to just start with any questions that come from the audience, and while is this okay? So please come to ask your questions. Dr. Chelani, are you still with us?
Yeah. Yes, Jana.
Wonderful. Okay, so I'd love to just start off by having you tell us a little bit more about how you had to change the physical space at Safdarjung in order to have a mother NICU. Because I know this is a question that comes up very often, and we heard from Professor Abun about how they had to rearrange some rooms and some physical space. I know even at Karolinska, when we toured there, that was another factor. But I know you did a pretty big shift in how you planned and used your space at Safdarjung. Can you tell us a bit about that?
Yeah. Thanks, Jana. We were lucky that, we were. Hello, am I audible?
Yes, we hear you well. Please go ahead.
Yeah, okay, thanks. So we were lucky that we had a space, in the department, in the block of the mother-child health unit, where we had the IVF center at the ground floor, and the roof was there for us. So probably we acquired that space, and with the collaboration of the obstetrics team, we got the approval from the medical superintendent, and we created the new infrastructure. But I do agree that there is always a challenge when the space is not available inside the NICU. Like as even mentioned, 3 countries, 3 sites out of the 5 did not have enough space to make the new an mother newborn care unit. So
Mm.
I feel whenever there is going to be a new development, new MCH block or construction, there probably the new unit can be planned. Otherwise, it is going to be a challenge for the existing space. Over.
Thank you so much. Yeah, one of the things that really impressed me when I toured your unit was the effort you had gone to make a bathing area and a cooking area right there off of the unit where the mothers could go. So being able to have a place where all of a mother's needs are supported right there in that space, I think just contributed so much to the success in your setting. Do I have any questions from the audience, or shall I keep going with my own? Yes, please.
So my main question.
You can repeat it, Jim.
I'll repeat it. Go ahead.
My main question is in terms of public care, the availability of one of the parents. So in the United States, one of the things that we face is availability of the parent in terms of family leave policy in particular. Do the principals have an idea in terms of any type of either dose effect or whether it matters, whether it's the mother or the father or a different caretaker?
Yeah, great question. So the question was, in the United States, we obviously face a big challenge with the availability of a parent and getting paid leave to be in the hospital. And so can you comment on whether or not you think there was a difference in the outcome if the mother was the one doing kangaroo care or the father, or the sort of dose response of how much time the baby was skin to skin? Maybe Abun, you could start.
Yeah.
You can take off your mask. We'll hear you better if that's okay. It's on.
Okay. So thank you for the question.
It's on. You can hear you. Yeah.
Okay. So the findings of our study showed that the longer the kangaroo mother care, the better. That means it's dose related. However, we did not analyze for whether it was by surrogate, by father, or by mother. We didn't do that differential analysis. I don't know whether we have.
Of course, a very relevant question, and I could say we don't have enough data to give you this precise answer, but I think as much as possible is good, and as early as possible, I think. And you should always try to start with the mother for at least maybe 15 minutes, 30 minutes or something like that, and then go to the surrogate if it's needed. And we can definitely, throughout these decades of experience, we can tell there is a difference between the families where they have started immediately or after a week. Completely different ball game. So I would say go as early as possible. That's the most important thing. And then as often as possible. It could be 1 hour per day or 1 hour per every other day or something like that. That's much better than nothing.
But in the study, I believe it was the mean duration was 8 hours and 24. So I think there definitely is some sense emerging that 8 hours or more in a 24-hour period is really necessary in order to achieve these benefits. And in the United States, from at least my own experience, that's pretty rare, right? I mean, we do these kind of little, I'll call them micro sessions of KMC or skin to skin, which haven't been shown to have the same effect.
We did a study in Europe with 11 units, and at Karolinska, we were one of the top, and we had 8.5 hours median.
Yeah. Anyone else? Questions from the audience? Yes, Dr. Bress in the back.
Great presentation. Could you talk about older siblings? That was something that I kept coming back to, is like if there's just a long separation, any impact on older siblings who are at home?
Okay, so the question about what was the impact on the siblings of having the parents in the hospital for so long, essentially, right?
Thank you very much for that. One of the things that we had to change was to allow the families, including the siblings, to come into the NICU. Okay, we did not use the siblings as surrogates, but however, except on one case where the mother had a child when she was much younger, a teenager. So the girl was old enough to be a surrogate, and she brought her. In fact, we thought it was her sister originally. Apart from that, the younger siblings, they come in, see the mother at intervals, but they don't carry the baby. But I think
And also in your country where you have so much single rooms, private rooms, I think it's used. We in Sweden did have siblings sleeping over and also siblings doing skin to skin. But I mean, short visits and also sharing, father going home, take care of the and sometimes the mother could also go home instead.
Dr. Faruqi.
Yes, coming on to that one, how many rooms are we talking about? Is it the entire NICU that would need a mother bed in there? This is for logistics. I mean, how many rooms do we have? 58. 58. Do we need 58 rooms for those 58 children? Is it, or are there some children that will not be in that kangaroo care?
But the children don't want to be around in the hospital because it's.
No, the admitted babies, the newborn babies, or the premature infants, or that are in the kangaroo care. Do we need, like if we have 58 rooms in our ICN here, do we need 58 beds for moms or parents?
Sure. They should not be separated. I mean, you have big rooms, you have places. You in your country, it's easy.
You have good real estate.
I know most of our postpartum, but I mean,
yeah. Jenna, can you repeat the question for the Zoom?
Yeah, for the Zoom folks, the question was about if you have 58 rooms in the intensive care nursery, do you need to have 58 beds for moms? And the answer is yes.
And I think the WHO recommendation for now is still it's for babies who are less than 2,000 grams. Okay, so what has been found elsewhere that even those who are bigger could benefit.
But I can also tell you about this Karolinska experience. Actually, for the very preemies, extremely low gestational age babies, it's very taxing for the parents to stay 24/7 in the same room. So actually, we don't use that. We have ensuite family rooms in the same floor, very close. I mean, maybe 10, 15 yards from the intensive care room where you might have, you know how it looks like. And you have maybe twins or even triplets. I mean, it would be impossible for parents to stay there 24/7.
Yeah. Okay, so I'm going to pause with the questions right there. I'm trying to keep us wrapping up on time. Did you want to say something, Hema? Dr. Chelani?
Harish wanted to have any comment.
Do you have a comment about the bed situation?
Yeah,
go ahead, Doctor.
I wanted to comment on the space, because in India, the government hospitals, they have the policy of discharging mother and baby together. Of course, in the private hospitals, once the baby is in NICU, many moms, they get discharged. But in the government hospitals, we have that policy of keeping them together, and there is always a bed which is given in the postnatal ward. So I think when we are making the new structures, like for example, in Safdarjung Hospital, the new MCH block is coming. So what we have done is there in the planning stage that 60% of the babies and the mother beds have been created together, and rest they are in the postnatal ward. So I think, yes, space constraint will be there, but once we are making the new structure, that issue can be sorted out.
Thank you so much.
Okay, so we do want to see the video, but we'll do that as we're closing, because I think we'll have our Zoom audience who also needs to get back. And our trainees, thank you so much for joining from your workrooms. And we had 75 additional folks zooming in addition to the really great group in person today. But many of those 75 were also workrooms of trainees. So thank you all so much. And I think for us to ponder on the way out, there was a great question that came in from our online community, actually from Dr. Balasandram, who's one of our colleagues at El Camino Hospital, who's really leading the charge on families as partners. And she says, for all of us to think about, we are really working on changing our healthcare providers' mindsets about family inclusion nationally. How can we do that? And I think one of the things that really leads our mindset, and I hope that we can all adopt this for the rest of the day, those of you who are joining us for the practice sessions, as well as we go forward, that we're really trying to change the framing of we don't do that here to how can we do that here? So I really challenge all of you to think about, this is not just Nigeria or Sweden or India, this is here for us in San Francisco. how can we do this here? So I thank everyone so much for being here and engaging. We're going to watch the video, and then I'll have some additional announcements for those of you who are able to spend some of your afternoon with us practicing iKMC and starting us down our path towards iKMC. So thank you so much. All right. See if this works. We can shut down if we need to. Great.
I'm happy to share with you some of my experience from a clinical practice on immediate skin-to-skin contact directly after birth for all babies and mother-newborn couplet care. And this is a way to keep mothers and infants always together.
It stopped working.
We're not activating the video.
This is Benjamin, born in week 32 vaginal, and he's put
You can try the link.
Try the link.
That's the
Try the
try,
link.
right? The MP4 file.
That's the blue one.
Try the link instead, I don't know.
Try the link.
Or mom.
Yeah. This doesn't match. So this is the. That's the thing. Yeah.
There we go.
All right.
I'm happy to share with you some of my experience from a clinical practice on immediate skin-to-skin contact directly after birth for all babies and mother-newborn couplet care. And this is a way to keep mothers and infants always together. This is Benjamin, born in week 32 vaginal, and he's put
Sina, come up and
Mary. Well, it was good.
you can talk to the pictures with the mic, with the mic.
Well, he was
It's
with
not on.
immediate skin to skin.
Skin to skin, as you see there, CPAP directly on, and then he was just kept skin to skin. He got an NG tube, and he was with his mother for 7 hours, skin to skin, the first 7 hours. And here is a C-section, preparation room for C-section. And we use long tubings to be able to reach to the surrogate, in this case here, the sister of the mother. And all the care is just as always. It's just the place of the care that is different. So we have preparation here for surfactant treatment, for peripheral lines, for central lines, whatever you usually prepare for a baby that you're expecting. And we have mobile equipment with a wheelchair and everything needed that we have on, same as we have for the shuttle and the incubator, we have here on the wheelchair. And here is a father prepared for immediate skin to skin after a C-section. and it's for a very preterm infant. So the midwife puts the baby to the father after late late cord clamp and a quick assessment from the midwife if the baby has a good tone and so on. So the baby is then put skin to skin, and we put immediate CPAP and evaluate respiration. We put monitoring on as usual, and we keep the baby in a safe position. And a safe position is really to have all the equipment that you usually have and that is needed for the baby, to keep the baby warm with special blankets, and to have a safe position with nose slightly upwards and close to the parent's cheek in kissing distance, we call it. So high up on sternum. And we have these special heating blankets, wool blanket and special insulating flectalone blanket. And here you see the very small baby that was put first to a resuscitation table, and then at 8 minutes of age, she was put skin to skin with her father, and we could go into the operating theater where the mom was still finishing up the C-section. And it's a small baby of 900 something grams. This is possible also for twins. So twin one always comes to the father or surrogate because the mom is still in labor with twin two. So then twin two comes to the mother instead, or to the mother. And these were born in week 31 plus 5, these twins. And you see a lot of equipment because we have then mobile equipment for both, one for each twin. So it's quite busy. And here you really have to collaborate very closely with the obstetrician department. And this mother was amazing. She started to hand express, and she got 10 milliliter of colostrum for each of her babies. That was given orally. I've never seen that amount. We put a peripheral line in skin to skin, and then both babies were transferred. The twin two was transferred to the father to be able to transfer them both into the NICU in a skin to skin position. And this is what transfers can look like. Week 28 baby, week 29 baby. And then as soon as the mother comes to the NICU, we move the baby to the mother instead of the father or surrogate. And this is really where the mother newborn couplet care comes in, and or the mother NICU, that we need to care for the mother also in the NICU. Yeah, we heard a lot of that already. And we heard about how we need the large rooms, the hospital beds for the mothers by every bedside for every infant in the NICU. We need the midwives to come into the NICU to evaluate and help the mothers. And we need to have a close collaboration with the obstetricians to care for the sick mothers too. Also with preeclampsia, also with infections. And by doing this, we can have continuous skin to skin. So this was the boy Benjamin again, and he had continuous skin to skin for a week. 7 days, they didn't put him in his bed, except for 8 hours in total for 7 days. And this is what we experienced happens when we do the immediate skin to skin. The parents just want to continue. And then we don't have the problem of not having the parent there because they are there. And also with this carrier system that the mother here can move about in the unit when the baby is stable and not with respiratory support. But we have movable monitors. So the mother is here visiting the rest of the family, sort of in the family area. And you can see this on YouTube. The film is there on YouTube.
Awesome. So I hope that got you really excited about doing some practicing this afternoon and seeing how this can look. So for those of you who are staying for the afternoon, and I hope you all are or can, we're going to be heading over to Mission Hall, right outside of Mission Hall 1400. We have boxed lunches. Please come and take one, enjoy your lunch, and then be back here in this room at 2. And the folks here have a big turnaround. They're going to set up tables so we can have some more community for conversation. Our experts will be leading us through simulations. We'll be hearing from some patients and really bringing the patient voice into the room. So we're just thrilled to have you and continue this afternoon. Thank you all so much. We'll be walking over Mission Hall 1400.